Thank you. This afternoon we have Dr. Annalee Yassi, who's a professor at the School of Population and Public Health at UBC, and she holds a Tier 1 Canada Research Chair in Global Health and Capacity Building. She's a specialist in both community medicine as well as occupational medicine. Dr. Yassi's research focuses on collaborative roles in occupational health and infection control in the healthcare workplace, issues and methods in community-based health research, transdisciplinary and north-south partnerships. She's interested in ethics in global health research, the link between clinical care and the social environment and determinants of health, an ecosystem approach to health, and the use of arts-based methods in health intervention research. Welcome, Dr. Yassi.
Hi. I realize that introduction kind of gives away my whole talk because every aspect of that is kind of the flavor that's brought to this, of linking various fields. Well, without further ado, what I want to do over the next probably half an hour to 45 minutes to allow us time for discussion is briefly review, first of all, why we're focusing on healthcare workers, why healthcare workers need protection, and the hazards facing healthcare workers. To do this, I'll use one of the online modules that we've created for training health and safety committees. It's being used internationally, mostly to introduce you to it so you can go back and play around with it when you have time to do other things. Then I'll talk about some of the data from our own work, especially in South Africa and Ecuador, but also some data from here in BC. We'll talk a little bit about the global TB epidemic because that's a huge problem for healthcare workers internationally. And of course, with this theme, how could we not talk about Ebola? So we'll try. I'm absolutely not an expert in Ebola, but so I get most of my information, like everyone else does, off the web and from the news reports. But it's healthcare workers are playing, and the protection of healthcare workers is huge. And then if we have time left, we'll do some sort of fun exercises that we have on how to choose personal protective equipment and the donning and doffing. So first of all, why healthcare? Why are we focusing on the healthcare workforce? Well, aside from the obvious that we're concerned about the well-being of all workers and all workforces, the healthcare workforce is the largest in the world, in fact, if you count all the various people giving care. And also an important workforce with respect to protecting the health of populations, but also because with globalization, there's been increasingly difficult working conditions for healthcare workers on a global scale. There's more casualization of work. There's more health workers are having to work multiple part-time jobs. Even not just support staff, but nurses and even doctors to some extent. Understaffing is a huge problem globally. And with increasing complex demands related to increasingly sick populations and aging populations, but also technological complexities that require learning new skills. We'll briefly run through various ergonomic hazards facing health workers, as well as the issues around violence and stress. Very briefly mention some chemical and physical hazards, but most of the talk will focus on infectious disease hazards because my Canada Research Chair is global health and capacity building, and most of my own work is focusing on protecting healthcare workers in low and middle income countries. And then, of course, epidemics, outbreaks always make the situations worse. Increasing occupational stress and burnout, demand for services increasing, and of course, risk of occupational exposure. I've used this slide quite often. It's from 2006, but I really like the imagery of it, that even though Africa has a fairly large proportion of the global burden of disease, the size of the dot shows you it has a very small proportion of the overall healthcare workforce, which is extremely important and why there's ongoing problems, but not the only factor. And this, of course, is driven by the economic disparity that when the funding all exists in places where the disease isn't, which, of course, complicates the situation further. The disparities in infrastructure reflect in healthcare workers having to give care to very large numbers of people. This is comparing Africa to the UK, but it's the same for Canada, North America, and the US. Just this was a nicer graphic, which creates a vicious circle. Conditions are lousy. People say they don't want to work there anymore. South African doctors come to Canada. That makes the situation all the worse in places where it's needed. So that was sort of the basic introduction on why are we concerned about protecting healthcare workers. To move to what are the hazards, starting with what right here in British Columbia, that the hazards range from musculoskeletal injuries to stress, time constraints, violence, and the other things that we had mentioned. In fact, back strain accounts for 33% of total injuries from healthcare workers, with patient handling the most important source of this, but causing hundreds of thousands of days lost from work, tens of millions of dollars. These are not small problems, and therefore they merit attention in terms of finding solutions, one of which is displayed here, mechanical devices. Our group recently conducted a systematic review of low back pain in nurses because the association of nurses with low back pain has been well known for decades. But there was, every once in a while, people say, oh, yeah, but it's a causal relationship. So we set out to look at that and found that regardless of nursing techniques, personal characteristics, or non-work-related factors, indeed, nurses are at higher risk for low back pain. Patient handling is the most important cause, but there are other nursing duties also elevate risk that confound dose-response relationships. But applying the Bradford-Hill criteria for causation, and by the way, if I say things that aren't familiar to you because I don't know people's backgrounds, feel free to stop me and say, what do you mean by that? But the associations are strong, consistent, temporarily possible, plausible, coherent, analogous to other exposures, with risks ranging from a 20% increase to over a 5-fold increase for this particular type of hazard, depending on the definitions of the outcome and the population at risk. Shift work, which of course will always be a factor in healthcare, causes sleep disruption, sleep deprivation, and the fatigue associated with it has been well documented to create a hazard for patient care, not just a hazard for the healthcare worker themselves. But there's increasing literature on the long-term effects of shift work, such as breast cancer and women working night shifts, with some references there. Violence is the next most important cause. 14% of all WCB claims in 2012 were for violent assaults in nurses. And there's significant underreporting, of course, because people don't want to report when they've been in a violent episode. People feel ashamed and they feel that they'll be blamed. So we know that this is just the tip of the iceberg. The chemical hazards in healthcare are also quite complex, ranging from waste anesthetic gases and cleaning products to chemotherapeutic agents. And the physical hazards are well known as well: ionizing radiation, noise, as you can see here, vibration, electricity, temperature. But I'll be spending most of the talk on the biological hazards. So I want to introduce you to one of the tools that we created that's getting a lot of play internationally. Let's see if I can do this right. This was designed, as I said, to train joint health and safety committees about their roles and responsibilities, how to conduct incident investigations and workplace assessment tools. But as there are some first-year students, I understand, amongst you, I just want to go through some very basic concepts that in terms of the various types of hazards and risks and the control measures. So for those of you following online, I guess they can see when I'm hitting a link, right? So the standard hierarchy of biological, physical, chemical, psychosocial, ergonomic. Some people put safety in with ergonomic. Some people leave it as a separate category, but they're here. Basically, the hazard is the source of the problem, and the risk is the quantitative likelihood of the outcome of a person being hurt, or whatever the outcome is. People tend to use those terms sometimes interchangeably, but they actually do have different meanings. As I mentioned, the biological hazards vary. What's important from the perspective of prevention is understanding the modes of transmission. So direct contact is particularly important, which is why hand washing is key. Indirect contact is also a source of transmission, which is why we not only have to wash our hands, but ensure that surfaces are cleaned as well. The droplet spread from people sneezing and coughing, or procedures like bronchoscopy, which is why we use masks and other protective clothing. When certain particles are small enough, they remain airborne, in which case we have to use N95 respirators. And there's also, of course, vehicle transmission, which is why we refrigerate things and do other things, and vector-borne diseases, which is a whole other talk in itself of how you manage vector-borne diseases. The physical hazards, as I mentioned, we're not going to say much about. You can go into these if you want to. Similarly, the various chemical hazards as well. But keeping in mind that the routes of exposure vary, it's not only inhalation, which is the most important route, but there's also ingestion, absorption through the skin, and injection. By law, there have to be material safety data sheets for all chemicals in the workplaces. You can click on these and get more detail on certain things like reproductive toxin sensitization and so on. The ergonomic hazards, you can play with the examples if you want. But all of these are easily remedied. For example, in this example here, what would you do to alleviate this problem? Yeah, exactly. You know, then you don't have to avoid the reach. And same with the others. The tools go into similar kind of exercises of how to make sure that you can select the right tools. And the various stressors. And I won't go into any of these as well, but I wanted to move to control measures. That it's useful to have a framework to look at control measures as well. You know, education and training is very key. Changes to the physical work environment, new equipment repairs, new policies and procedures. There is, of course, a hierarchy of control. These aren't equally effective. Controlling a hazard at the source is the most effective. Then along the path with engineering controls or administrative controls. And the least effective are personal protective equipment and controls that are at the level of the person. So if we use the example of noise, what's the most effective here? Wearing earplugs, purchasing noisy equipment, which of these is the most effective? Okay, so less noisy equipment. We'll put that here. Okay, oops, purchase less noisy equipment. Why didn't do it like that? Maybe because I'm not good with this mouse. That should be the most effective. Yeah, that's it. It won't stay there if it's not. What's the next most effective in these things here? Yeah, this will stay. Oops. I'm just not good with the mouse. Anyways, you get the idea. And you know, then would be wearing earplugs, and the least effective would be just training people not to stay in a noisy room too long, which people often can't do, so it's the least effective. It's not up to them. But well, you can do the same kind of exercise in motor vehicle, in other words. Training is always important, but you can't be trained to do the wrong things right. If you don't have the right equipment, and you don't have the right layout and the right tools, all the training in the world won't help. So when people always go to training, but they don't always go to making sure that all the other things are in place. I won't say much about monitoring. Again, you can look at this when you wish. Let's see how to get back to this back into my PowerPoint. So we've been working, as I was saying, with the WHO as a collaborating center. In 2007, the Pan American Health Organization wanted our group to come in and help with workplace assessments, and particularly infection control. So we did an assessment in the Amazon, in one of the hospitals, as well as in a pediatric hospital in Quito and in an adult hospital. And in doing these, it's always good to highlight what's going well as what risks need to be fixed. Otherwise, people get overwhelmed. And in this particular hospital, this one was the Amazon one. They did have a medical waste program, puncture resistant containers, and health promotion strategies, but not enough soap and water. Hand hygiene was lacking, and people were recapping needles. So we knew that we had to focus on that. And that we also did a workplace survey and found that people did acknowledge that they were having blood and body fluid exposures and not reporting them. And the overall knowledge wasn't very good on our knowledge, attitude practice questionnaires. If you want more detail, here's the reference from that particular study. We've done quite a bit of training in Ecuador and in the Caribbean under the auspices of TAHO. Sometimes we have to be creative in where this funding comes from. This was before there were Pan Am Games or Caribbean Games, and so there was a lot of money available to prepare people for biological terrorist attacks. So even though the likelihood of a biological terrorist attack is way less than any of the problems we see on a regular basis, that it tends to be what funded some of our work. But more recently, because in Ecuador, the Ecuadorian government's been doing a really good job of trying to modernize and make the public health system more efficient, so has been trying to beef up the accessibility to care. But in doing so, was forgetting about what it meant for the people giving the care. And so we conducted a survey in 2 Ecuadorian hospitals and found very high levels of, for example, 77% of people were using the Matlock-Bernard scale were characterized as moderately burnt out. And interestingly, the various hazards, physical, chemical, biological, ergonomic, and so on, were reported clear across the different services, with the exception of ergonomic hazards that the radiology people weren't reporting because I guess they sit in a room on a nice comfortable chair and read x-rays, but or whatever. Similarly in South Africa, which is really, of course, land of disparity, we visited various hospitals to decide on where we wanted to work, and picked Leone Hospital because of the need, but also because they had a functional health and safety committee and had good support from various other perspectives. So we did a workplace audits in various hospitals and a questionnaire, actually of about 1,000 workers in 3 large public hospitals, and again found that sharps containers were not being used properly, they were overflowing, N95 respirators were either not available or not used correctly. There are no disposable towels or soap. This has also been published. And the questionnaires kind of matched what we found. People were washing gloves rather than disposing them as they were supposed to do, and not wearing their protective equipment properly. A large number of people hadn't even been screened for TB in a country where TB is huge. And this creates a lack of trust in managers and contributes to people deciding that their safety and health is at risk, so they leave, and then we get into that vicious circle that I talked about. But one of the components that's particularly important, again, is infection control and the proper use of personal protective equipment and having proper supplies. So we conducted a certificate program and trained about 32 health workers, people in charge of occupational health in hospitals and infection control. And we invited the CEOs. We told them the unions are going to be there, so they had better show up, as well as provincial executives. And they listened to the reports from the different groups of people in our hospitals and promised to do something about the hazards we found. Unfortunately, people change jobs very often, so the people in charge are no longer in charge, and we'll have to start all over again. We work very closely with other WHO collaborating centers, and these folks are from a WHO collaborating center, the National Institute for Occupational Health. Those people doing occupational health internationally, it's always good to sort of touch base with whatever WHO collaborating center for occupational health is in the area. This pink dot on his forehead, he's from the ILO actually, was because we were doing a stigma exercise. Stigma is a huge problem, and when we talk about Ebola, we can talk about the wisdom of this going around to houses and identifying people, and it's really a double-edged sword. We also did some air sampling and personal sampling in a large hospital. You could say, what was the point? We already knew there was TB, but we thought if we quantified it and showed where it was and stuff, it might create, increased incentive to allocate resources. And so we attached personal samplers to some doctors and nurses and phlebotomists, and found that the 22% of the samples that were positive for airborne TB, interestingly, not only in the medical areas, but also in non-medical areas, including admin offices. So it meant that people who walk in and out, either the courier or porters or cleaners or whatever, would be enough to, even if the person whose office it is didn't have TB. We were happy the technology worked, that we're able to measure it, but it doesn't necessarily help in solving the problem. In short, to end this section of the talk, the healthcare workers in the north, the global north, that is us, face different risks: musculoskeletal injury, violence, stress, etc. We certainly have influenza. SARS was a wake-up call for those of you who were around that we're not immune to infectious disease outbreaks even here. The global south has all the same problems plus more, and particularly TB, where since I'm doing work in South Africa, we're really acutely aware of multiple drug resistance and extreme drug resistance. And now with Ebola making the news, adding yet another dimension of fear and hopefully a wake-up call that we need to take these things much more seriously. So to move now to the global TB epidemic. Anyone have any comments or questions before I move on? I'm going to try to end with enough time for discussion afterwards, so I'm going pretty fast, I know. But you can see that the darkness of the color reflects the intensity of the epidemic. A third of the world's population is infected with TB. It's projected with drop of nuclei into the air that can turn, I love this graphic because it says it all. That there have been many studies over the last 15 years and consistently showing that healthcare workers are at higher risk for TB, going back to 1995. Another systematic review that was done in 2011 found healthcare workers almost 4 times higher at risk for TB. Again, emphasizing that internationally we need to do a much better job at TB infection control. The increased risk in healthcare workers is a reflection of infection control in the workplace. Now with multiple drug-resistant TB and extreme drug-resistant TB, the risks are even higher for health workers, almost 7-fold increased risk for health workers for extreme drug-resistant TB. So although this doesn't make the news the way Ebola does, this is still a much bigger problem on a world scale. And again, we have to put these things into context. It's not that we have to train people so they know what to do. We have to understand the economics and the politics behind what's going on. And in the case of South Africa, the irony perhaps is that the end of apartheid, which was a horrible system creating intense disparity, after apartheid fell, there was much more integration to the global systems economically, which stimulated more disparities. South Africa's joining the World Trade Organization meant they had to drop their protective tariffs, which meant they lost over 500,000 jobs, which increased poverty. And that was just in this period right after the apartheid ended in 1994. The World Bank and International Monetary Fund has pro-corporation policies that make it impossible for governments to allot a large percent of their budget to education and healthcare. So there's inadequate funding that goes for healthcare, which perpetuates inadequate infection control, delayed diagnosis, delayed treatment. We had a medical student who did a global health research internship with us, and this was all such an eye-opener for him, that how much poverty related to health. So we just published that in Medical Teacher, his observations about the relationship between the global economic situation and control. So what can we do to prevent the spread of TB in healthcare? Give me a break. Somebody else. What are some of the things we should be doing?
Hand washing is one thing, right?
Okay.
Protect the soldiers, the people that are in contact with those who need them.
Okay. Oh, okay. Okay. Well, hand washing, personal protective equipment, between patients. I might as well just move on. It's important because there's so many things we could do. It's important to have a framework, and we talked before about the hierarchy of controls from with control at the source, along the path, and at the person. In infection control, the people in infection control have a bit of it matches, but it's a bit different. They start with administrative controls, whereas in occupational health, we always start with control, sort of the engineering controls. But the control at the source for infectious disease is our administrative controls, as you'll see, then the environmental controls, then personal protective equipment. So administrative controls, starting off by screening patients who are coughing as they enter a facility and isolating them, giving them masks, tissues, make sure they know about cough etiquette, coughing into their elbow, for example, or their shoulder. The reducing waiting times so people aren't sitting in an open air coughing and spreading their disease. Having a safe area to collect sputum. The training and education, screening protocols, responsibility for infection control. It's mind-boggling to us that even in 2014, most of the facilities we go to don't have clear protocols on these things. And the reason isn't because people are stupid, it's because staffing is so strapped and patient care is such a priority that they don't dedicate people they need to dedicate to occupational health and infection control. And so we're trying hard to change that mindset working with our partners. To move from admin controls to environmental controls, the most important environmental control is opening windows. This is an open window. Well-ventilated areas. Here in North America, we could use negative pressure rooms, use of ultraviolet germicide radiation. And then we turn to personal protective equipment. As you folks are occupational health people, I'm sure you know the difference between a mask and a respirator. The mask protects other people from the wearers. The respirator protects the person wearing the respirator, so they're designed differently. Aside from the proper mask or respirator, we encourage people to know their HIV status, to take prophylaxis, because the HIV epidemic drives TB. People who have deficient immune systems are more susceptible to TB, which creates that vicious circle as well. And of course, the training and infection control. There is some activism around preventing TB. You see wearing a mask, wanting education, and and we'd like to see the unions even more active on these areas than they are, but certainly public pressure makes a difference in terms of allocation of resources. There's lots of material out on basic working conditions on all these issues. If you go to the ILO or the WHO, this is one we did collaboratively. Our group was involved in putting together policies on infection control that strengthen the integration of occupational health and infection control. So to move now to the Ebola outbreak, even though it's in the news, I again want to stress that the everyday run-of-the-mill things like HIV and TB, which we've heard about so often, so we tend to sort of become blasé about, are still the main drivers and threats for the health of healthcare workers. We hope Ebola gets under control really quickly because it has the potential to, of course, spread very rapidly and has a very high fatality rate depending on where you are. Up until now, the outbreaks occurred primarily in remote villages in Central and West Africa. But then as soon as it spread into larger cities, it spread very rapidly. It was believed to have begun in Guinea, where people were more in contact with wild animals, which of course is where a lot of these new outbreaks, even HIV, started. And then it spreads human to human. I think as of a few days ago, there were almost 5,000 cases and almost half at the death rate of almost 50% in those. We are into an exponential growth situation, so that we can't minimize the importance of this on a world scale. Particularly when it moved beyond the villages and somebody going into Nigeria and has gone up. Why the epidemic? Which is, we focus on it, we need a vaccine, and we, of course, do need a vaccine, but there'll be more outbreaks like this, and especially with climate change, changing habitats, more contact with wild animals, the likelihood of mutations. So we have to look at the underlying infrastructure that drives these conditions. Where these outbreaks start, there's been deterioration of roads and public infrastructure. When food prices have been going up, and when people can't afford to, go out to the Safeway and buy their food, they turn to hunting wild animals and cooking them and eating them, which was a factor in this epidemic. Climate change, changing the habitats, both in terms of food production and consumption patterns and more contact. And traditional practices without proper sanitation. In one of the countries where Ebola has gone really out of control, some of the traditional healers were engaging people in washing bodies and doing their traditional way of handling the dead, but without proper sanitation, it just created a huge spread. So that was a problem. There's huge distrust of healthcare professionals, which on one hand means that people are avoiding going to hospitals. And those people who heard the news yesterday, I think it was 8 healthcare workers were murdered by a group of people who felt the healthcare workers were making the outbreak worse. This idea of going house to house, identifying people, putting an X on their house, is potentially a horrible situation because people will hide they're sick, because people need to go to work. They know that identifying somebody sick in their house means they'll be ostracized. So, unless they have the infrastructure to deal with people they identify, it could just make the situation a lot more problematic, delaying care and isolation. You've all seen, pictures in the news of what the conditions are like for treating people, and as well as what the personal protective equipment kind of looks like. And a picture of the foods they were eating that were thought to be at the source of things. We won't go into the clinical aspects of Ebola. Suffice it to say, it's not a pretty death. Lots of, it's hemorrhagics, which means there's lots of bleeding. So there's lots of potential for blood and body fluid exposure, as well as, urine, feces, vomit, various secretions. The incubation period is up to about 3 weeks. So if someone's been exposed, we want to keep them isolated for at least 3 weeks to make sure that they haven't developed the disease and are a source of infection. Why so many healthcare workers are getting infected and dying? First of all, there's a shortage of personal protective equipment. The countries have been slow to send money. I think Canada has just committed, I don't know how much money, but to send personal protective equipment. But there's also improper use, and we'll talk about that with my linking games if we have a chance. Inadequate sanitation resources, inadequate supplies, far too few medical staff. When the outbreak began, Liberia only had 1 doctor to treat 100,000 people in a population of about 4.4 million people. So there's huge understaffing. People can't easily be identified and treated the way they can here. Even if you identify them, there's not the conditions. So it's not a surprise. These aren't unexpected, like how in the world is this happening? We know that. And then medical staff, because they're stretched so thin, work far more hours than they should work, leading to fatigue. Mistakes are made. People can't follow proper safety procedures when they're tired and overworked. And again, we have that vicious circle that I mentioned earlier on. I think this one will work. We'll see. But one of the no, it didn't work. Okay. So that didn't work when we tried it last time. Yeah. Should I hit it again? Okay. We can cut and paste it. Yeah. Here, I'll let you do that. I'm better than those. But what we did, I'll tell you the background to these things. Is part of our work with in our WHO Collaborating Center is we created tools that could be used to train health workers. This one was created at the time of the H1N1 concern, the pandemic influenza. I won't review the infection. Well, maybe no. I'd rather have time for discussion. So what this does is create some scenarios that if we take airborne and contact precautions, which has to be used. This one was had to do with a patient. The scenario was a patient just had a bronchoscopy, which creates aerosolizing, and is suspected of having had SARS. And we asked you how would you protect Patty? So what's the first thing she should do? What? Oh, the sound's not on. Oh, well. It's neat when we have the sound on, but I don't know how to put it on, so I never brought it. Okay, after that, what does she do next? All right, well, let's go to the unidentified gospel. What does she do next? I have to admit there's a bit of a check. Since we didn't do the little promo, she didn't have to fit check. If you've just done the exercise, like the pre-stuff, then you'd know that you have to do that. So that was a bit of, so always remember to fit check. Now what does she do? Okay, after you get two wrong, they kind of tell you. So, okay, so now, now, okay, now, so now she's done. So what does she do now? I have to tell you, the first time we did this, our developer had her throw them in, and Paul made us redo the whole thing because they said you can't throw it into the place it carefully. So you had to redo the exercise. So now what does she do? She leaves her gown first in the contaminated room. In some jurisdictions, they say wash your hands first, but in many places there aren't sinks in the patient's room, so you have to leave. So that you have to consult the local. So now she's out of the room. What does she do? Now what does she do? Now. And now. Yeah. Wash your hands again. Yeah, we didn't have the sound turned on, so you don't hear all the sound effects. But if you did, you'd hear clapping. We've also just created one that's Ebola specific, which has some differences to it. I'm not sure if this is going to work. Oh yeah, that's right. No, yeah, okay. Now this one was just created yesterday, and so there's a bunch of stuff that needs to get fixed. The scenario, of course, is not a hospital room, but in addition to the standard things. So what do you do? What does she do? Because what she should do first is wash her hands, but the guidelines actually don't talk about that. They talk about the first thing being put your boots on. I guess because they figure the boots are dirty, so it's better to wash your hands after that. So put your boots on, then what? But they say so that you can then get your gown, and you have to take an impermeable gown. If there's no impermeable gowns, you use a cloth gown with an apron, because the fluid, this is blood-body fluid transmission. Then what? Well, let's see. Then what? Well, this is actually, they say goggles, but we're going to redo this because I'll tell you that because First of all, because there's some skin showing, and you shouldn't have any skin showing at the neck and at the. This was just done pretty quickly, so Steve's going to redo this because it should cover the whole head and face because the concern is that people may inadvertently touch their face. You know, they forget there's a mosquito or something or whatever, and so as extra protection, what you see people wearing, that has to get fixed. And then if you use the things that the Médecins Sans Frontières use, those kind of bonnets, the goggles go on top. Anyways, so put her gloves on so she can enter the room. That's because you have to watch your hands. Yeah. Not as good without the sound effects. Anyways, you get the idea. Enter the patient's room. We use the same patient because Ebola everyone's susceptible to it. And then what do you do now? What does she do now? In this case, you don't have disposal stuff in the patient's area. In fact, you'll have many patients, so you have to leave the area. People get, they don't have private room situation. So what does she do now? Yeah, we're actually going to redo all of this because the guidelines are that you take off the gown and gloves together, but it depends on what kind. So Steve's actually working today on redoing this with much more detail because it's thought that the reason, in fact, I'm just going to close this I'd like to get back to my PowerPoint. Yeah, thank you. It's thought that even people who've been wearing their personal protective equipment, health workers have been getting sick and dying. And so the question is this personal protective equipment no good? And things are only as good as wearing it properly. And so the thought is that people are self-contaminating when they take off the equipment, they take off the personal protective equipment, which is why we're focusing on having tools available to help people really learn how to do this without self-contaminating and in various courses. So Ebola is a contact and droplet spread kind of situation, but in addition, the gowns have to be impermeable. There has to be more attention to the goggles and face shields. Double gloving in some situations, disposable shoe covers, leg covering. So this is, as you know, what people look like right now. So it doesn't help when folks like that show up in a village and start, marking. It's understandable why there's fear, and it's even more compounded when people hear that their own doctors are dying, yet the Western doctors get thrown out, which leads people to feel like there's a big conspiracy here. I won't go into that, we already have, but the main message of this talk is that healthcare workers need to be empowered by their organizations to consider their own safety as paramount for needs for patient care. When you go get on an airline, they tell you put on your own oxygen mask first before you help another passenger. That's got to be the message that whether we're in Canada or whether we're in Africa, protecting the healthcare workforce is essential, not only because they're human beings in their own workforce, but they're necessary to take care of patients well into the future. So I end there and leaving some time for questions and discussion.
Okay, just a reminder that if you're in the room, you need the microphone to ask a question.
Thank you. So you showed the graph showing that it was, for Ebola, it was still in the exponential phase.
Yes.
Do you know anything about predictions of the future?
Well, I get all my knowledge the way you do, which is off the news, from the web, because I'm not, although I am very involved with what's going on behind the scenes with the WHO on TB and HIV, I'm totally uninvolved with what's going on in Ebola. So that's the caveat. But what I hear is that we are far from out of the woods on this situation, that they're still talking about exponential growth until the countries really ante up and get equipment, get personal protective equipment, get training out to these places. We're still into exponential growth. That's my understanding. I certainly hope that a side benefit of what gets done in the next little while is building capacity locally. Because if all we're doing is flying in people with their zoot suits on, and I just don't think it's going to be sustainable. So Ebola is going to be around for a little while still. Of course, in SARS, people didn't know how long it would take, and that got under control pretty quickly. But mostly because SARS was in countries that had good infrastructure. And so we were able to isolate people and get infection control implemented. If anyone else, by the way, has comments on any of these, I don't profess to be an expert on all these topics, so please feel free to put up your hand and say, I want to add to that or something. Go ahead.
Thanks for that. I was just curious what the local tuberculosis kind of picture is for BC.
I have a graph on that, but I don't want to take the time to look at it. Basically, there's a huge difference between the Aboriginal population and the non-Aboriginal. We have pockets of people that are foreign-born that have much higher rates than local. So we have pockets, downtown east side, Aboriginal populations, foreign-born from high-risk areas are quite high. But in general, we have maybe, say, 3 per 100,000 compared to 1,000 per 100,000 in South Africa. They have about a 300-fold greater risk than we do, to put that into context, with the exception of those subpopulations. Can I ask a follow-up? I guess. Yeah.
I was just curious if you know what the protocols for our paramedics and stuff are for going into, say, the downtown east side and stuff like that. Is it quite stringent with regards to personal protective equipment or?
I think it's quite variable as to how much training is actually put into place. In general, I think the paramedics and the people in the community have the sort of least good attention. Certainly when for H1N1, they were getting left out routinely from protocols and procedures. Because I'm more focused globally now, I'm less on top of what's happening in the local scene. So I certainly want to allow somebody else to comment on it. But in the acute situation, I'd say, like in acute hospitals, I think our healthcare workers are very well taken care of from an infection control point of view. I think less so in long-term care and even less so in the community, but still much better than anything you've seen in Africa. Ed?
I was just wondering, how long can the global supply chain keep up with the requirement for PPE and equipment to help contain Ebola, right? You go through a lot of gowns and gloves and whatever.
Yeah, really good question, and that's something that I really should look at. I don't know whether the manufacturers are revving up production. But good question. I don't know. To other people.
Yeah, I just want to touch on some of your reasons why it's difficult to control infectious diseases in Africa, based on my experience in Africa. One of the reasons you gave was the food prices. That because people can't afford food, they go hunt the wild animals for food. But even at least in Nigeria, where I come from, wild animal is a sought after meal because even if you can afford the food, you want to eat wild animals.
Yes.
Because you believe it's more delicious than the cows and the chicken.
Yeah.
So it's even among the rich, they will go and pay top money for the wild animals.
Yeah,
just
good
for them
point.
to be able to eat it. So it's
good point. And thank you for that, because you're absolutely right. These things are delicacies, and so thank you for that comment.
Hello, thank you. We've heard reports in the media about how it's been difficult to combat Ebola in some African situations because of local superstition about the cause of the sickness and the role of outside workers. Is that really the case? Is that really what's going on? It feels like it's a bit of an easy answer just to say, oh, the locals are superstitious, so they're giving our doctors a hard time.
Well, I think first and foremost, that I'd say it's the public health infrastructure and the healthcare infrastructure. If we say who is to blame or where is blame, I think it's the weakening of the infrastructure that drives the epidemic, not people's superstition. But the next thing I'd say is sometimes people's beliefs come from experiences. And if people feel that they haven't been treated well, that they haven't been respected, that their customs haven't been appreciated, that they do, have sort of stigma and suspicions. I don't work in that part of Africa, I never have, but in Ecuador, when we've worked in indigenous communities, people would always say, oh, some of their customs is like what causes a lot of maternal death because they do things like, bury the placenta with the dead, and they have the midwives and so on. But all these things come from the fact that when people who have very strong indigenous, ancestral knowledge go to the Western healthcare system, and they're treated badly. They feel they're not respected. They feel they're scared. It drives a sense of otherness. And so, is it a factor? Absolutely, I'm sure it is. Even though I haven't been there, perhaps our colleague here could say more. In South Africa, well, I dare say misinformation, but about HIV was a huge factor in driving it. People had all kinds of weird ideas about where HIV came from and how it was transmitted. And you had a minister of health saying, all you have to do is take a shower. Well, actually, the president said all you have to do is take a shower. At one point. But there are beliefs that are a different worldview from ours. But we have to not think of them as ignorance. We have to think of them as a different worldview that needs to be respected and understood and worked with. So maybe our colleague from Nigeria could comment on that. But
brief comment on that. Culture is a big part of it, really. And another aspect of it is mistrust of the white people. It's part of it. And I don't want to go on and on. And I think it will be, the Western effort will be more effective if we try to incorporate the cultural practices into the prevention. Like, don't tell them to stop their culture of how they treat the dead, but instead, when you practice your culture to treat the dead the way you treat it, what can we do to protect you in that process?
Absolutely.
Because if you tell them, okay, don't touch it there, don't treat it that way, then they'll be like, who are you to tell us what to do with our dead? That's the way our ancestors have done it for thousands of years. So it's better to work with them on, okay, that's how you treat your dead, but how can we protect you while you do it?
Yeah, absolutely. Thank you for that. Intercultural respect is hugely important.
You mentioned that about 1/3 of the world's population are infected with tuberculosis. Is that the figure?
Yeah.
My understanding is that some people, or a large number of people, are just carriers and are not actually diseased. Do you know what proportion of that are diseased? And do carriers often convert from just being a carrier to being diseased?
Yeah. Again, I have a slide on that, but about 15% of people who have latent TB, in other words, 1/3 of the people we're talking about are people who have the infection in them but aren't sick. About 15% annually or so of those will develop active disease. And that depends on the immune system of the people. And then it goes down, that's in the first year, and then it goes down as people go on. But HIV drives it in a lot of situations. A lot of other diseases, silicosis, it drives TB and various other things. So young people, old people, people who are at risk from other things have a higher likely of going from being a carrier to getting the active disease. So, and then also reinfection and things like that. So so I'd say roughly maybe 15% of that would be people who have active disease, and then it depends on how quickly they're treated.
Okay, if we have no further questions, we'll thank Annalee for her presentation and lots to think about.